Hello, welcome to case-based learning of cardiac MRI on mricardiac.com. 32-year-old male marathon coach presented with reduced exercise capacity. He went for a routine cardiac checkup and 2D echocardiography, which revealed mild concentric alveolar hypertrophy. Cardiac MRI was suggested for further workup, and it shows presence of mild concentric alveolar hypertrophy. The maximum end diastolic wall thickness was 16 millimeter, so it was just borderline. LV function was within normal limits. The left ventricular global longitudinal strain showed borderline reduction. Normal values are in the range of -19 to -20, but in here it is -17. The left atrial indexed volume, again taken from the area biplane method, it was slightly increased. There was subtle late gadolinium enhancement in the interventricular septum. T1 mapping values were also mildly elevated. However, ECV was within normal limits. So such cases present a common diagnostic dilemma to differentiate physiologic remodeling of athlete's heart from pathological hypertrophy. It is important to differentiate them because athlete's heart does not require any therapy, while pathological hypertrophy requires a close follow-up because they have high incidence of sudden cardiac death and heart failure, and also may require some pharmacological intervention. Sudden death during sports activities have a lot of social and clinical impact, and it is important to differentiate it from HCM at an early stage so that we can appropriate guide the patient and prevent catastrophic events. Few MR parameters, few clinical and MRI parameters to differentiate this such type of borderline alveolar hypertrophy. It is important to take the family history of sudden cardiac death or HCM and compare the degree of hypertrophy with the intensity of the training. So with mild training, if you have significant hypertrophy, then it is definitely not normal. ECG abnormalities will favor HCM along with disproportionate left atrial dilatation, reduced strain, and presence of diastolic dysfunction. All these features will suggest pathological hypertrophy. HCM usually have asymmetric pattern of hypertrophy. The septal wall is usually more thickened, and that probably may give an important clue. Also important to look for the LV cavity size. The LV cavity size will be reduced in HCM, but it will be normal in athletic patients. Presence of SAM and left ventricular outflow tract obstruction will be seen in HCM patients, along with late gadolinium enhancement, which is classical seen in HCM patients. However, most importantly, athlete's heart, once they stop training for at least nearly 3 months, the hypertrophy reverses. And this is one of the most important differentiating features to differentiate it from the normal or borderline alveolar hypertrophy. Few other important clues, as discussed earlier, presence of SAM and LVOT obstruction will favor HCM. Cavity dimension, LV cavity dimension in end diastole, they will be slightly on a higher side, that is more than 55 in athletes, but HCM people will have less, smaller cavity in the range of 45, less than 45. HCM has asymmetric alveolar hypertrophy, and septal to posterior ratio will be always more than 1.2, while athletes have symmetric and concentric hypertrophy. Presence of diastolic dysfunction, left atrial dilatation is considered pathological. Most importantly, athletes, once they stop training, there will be reduction in wall thickness. So once they stop training for at least 3 months duration and you get more than 2 millimeter reduction in wall thickness, you can consider that this was physiologic change. Lastly, genetic testing may provide important clue for HCM. So as seen in our patient, in view of abnormal GLS, left atrial dilatation, elevated values on T1 mapping, and as well as this borderline alveolar hypertrophy with this kind of symptoms, pathological hypertrophy was strongly considered and genetic testing was advised. Lastly, it is important to understand there is always a complex interaction between genetic and environmental factors. HCM has wide range of phenotypic expressions, and sometimes even delayed onset can occur. There could be even HCM carriers or different phenotypes, and sometimes with positive genetic substrate, even physiological adaptations may be magnified. So we have to consider all along with clinical picture, and depending on ECG and genetic testings, we can regularly follow up this patient. Non-invasive diagnostic test which may be helpful would be echocardiography or cardiopulmonary exercise testing. They will provide also clue. Similar concepts can also be found on Cardiac MRI Simplified book. Any feedback and suggestion, please mail us on info@mricardiac.com. Thank you.